Thank you for attending this month's Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to, in honor of Pride Month, have Dr. Kenneth Mayer of Fenway Health, Harvard Medical School, and Beth Israel Deaconess Medical Center here to present Optimizing Sexual and Gender Minority Health. What do we know and what can be done? Dr. Kenneth Mayer is a physician who trained in the Harvard programs in internal medicine at Beth Israel Hospital and in infectious diseases at Brigham and Women's Hospital. As the founding medical research director of Fenway Health, he created a community health research program that has developed an international reputation for its capability to conduct community-based research, focusing on sexual and gender minority health and biobehavioral approaches to HIV and STI prevention. He is currently a professor of medicine at Harvard Medical School, a professor in global health and population at the Harvard T.C. Chan School of Public Health, and attending physician at Beth Israel Deaconess Hospital. Starting in 1994, he has been a site principal investigator of NIH-funded clinical trials units, focusing on biobehavioral HIV prevention research, and is a member of the scientific leadership of the HIV Prevention Trials Network. He has co-authored more than 1,000 peer-reviewed publications, co-authored the first text on AIDS for the general public, and has co-edited 5 academic texts. He has served on the boards of the Foundation of AIDS Research, known as AMFAR, HIV Medicine Association, and IAS, is an editor-in-chief of the Journal of the International AIDS Society, and is a member of the President's Emergency Plan for AIDS Relief Scientific Advisory Board. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 40 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Kenneth Mayer for Optimizing Sexual and Gender Minority Health. What do we know and what can be done? Dr. Mayer, the floor is yours.
Thank you so much, William. It's really a pleasure to be here with you today, and we'll see if the miracles of modern technology work. Can you see my slides or no?
I can see it. Looks perfect.
And is it advancing? No. Yes.
Oh, yep. It looks like it's on the.
Okay.
Now it's on the first slide.
Excellent. Okay. Well, greetings, everyone. It's happy Pride, and really a pleasure and an honor to be here with you and friends and colleagues at Ocean. We've been collaborating with Ocean for more than a decade in community-based research, and it's really been a pleasure to work with Jen DeVos, John Puro, and colleagues such as William and Anna and Corbin. So thank you again for the invitation. So what I'd like to do today is just tell you a little bit about the reasons why we think that sexual gender minority health training for providers is important, and then tell you some preliminary data from a study that we did that was funded by PCORI that also involves some Ocean sites. So just for those who are not familiar, Fenway Health is a federally qualified community health center. My role at Fenway, I am co-director of the Institute and also medical research director. And the Institute is within the health center, but it's the part that focuses on research, education, and policy. So the thesis of what I'm going to be talking to you about today is the need for culturally competent care. And the reason for this is that sexual and gender minority populations have a variety of health conditions that require unique and specific approaches, and certain conditions may be more prevalent than among cisgender heterosexual patients. But the reality is that sexual gender minority patients often receive suboptimal care, and this is often related to stigmas and providers not being well educated. And yet providers can actually be very important allies, and for people in the process of coming out, transitioning, they can be extremely important individuals. And so we really want to figure out how to promote information, awareness, and allyship. And we have to take as a fundamental principle that culturally competent care is a basic human right. There's been an increasing focus on these issues. So the National Academy of Medicine recently put out a report about less than 2 years ago, and basically focused on the importance of understanding the health of sexual gender minority populations, and why it's so important for the healthcare system to be responsive. It's an evolving process in terms of our understanding of sexuality and of gender identity. So I found this infographic to be quite instructive, that if you start off with baby boomers, 95% of individuals self-identified as heterosexual. But if you look at more recent generations, most particularly Gen Z, almost a quarter of individuals did not identify as heterosexual. And there are a variety of different sexual orientations that were identified that hadn't been described before, and certainly increased visibility of people identifying as queer, as asexual as an identity, and as pansexual. And I think this is important. And in addition, and something that I think for many people it may go without saying, but I think it's important to comment on, that sexual orientation is not the same as gender identity. Gender identity is a person's inner sense of who they are, and gender expression may be different than gender identity as well. And we traditionally think of individuals as cisgender, where the birth and gender identity are congruent, or transgender, people having a gender different than that assigned at birth. But again, increasingly in recent years, individuals have also identified as non-binary or queer, and recognition that gender identity and its expression can be fluid and can be on a continuum. And the use of they pronouns, for example, is a reflection of people not wanting to be limited necessarily by binary identities. This is the issues that we're going to be talking about today are not new. Some of the expressions of sexual orientation and gender identity have evolved. But more than a decade ago, I, with colleagues at Fenway, co-authored a paper about sexual gender minority health, and we basically identified some clear issues. We were not measuring sexual orientation, gender identity very well in clinical settings, so we needed better data. And the reason for better data is if you don't count, if you don't count, you don't get counted, or you don't count for anything. In other words, communities were much more invisible because questions about sexual orientation, gender identity were not routinely asked. And yet the data, if you look at the leading health indicators in the US general population, as of about 15 years ago, there was already a database that said that for most clinical conditions, there were health disparities and health inequities that were more prevalent among sexual and gender minority populations. And this is due to a variety of factors. Some are biological and some are behavioral. And this led us to also make recommendations about the need for multidisciplinary research. But one of the biggest issues was the clinical setting. And we also made the case for the need for providers to have more training and to be able to create a healthier environment, and one to create a welcoming environment so that one could interact early on and prevent various adverse health outcomes. The reasons why there are these health disparities among sexual and gender minority individuals are diverse, as are the populations are diverse. But we have to think in terms of the fact that there are some common social and structural issues. Certainly, the experience of growing up in a non-affirming environment has downstream adverse health consequences for young individuals, particularly who are less likely to be buffered. These may be exacerbated if other adversity occurs, such as poverty or childhood abuse. It's also important to recognize that certain behaviors may also lead to different manifestations of different conditions. So, for example, individuals who engage in anal intercourse will be more likely to have anal and rectal sexually transmitted infections than individuals who don't. So it's understanding people's specific behaviors, but also understanding some of the common social and structural factors that potentiate adverse health outcomes. The anticipation of receiving bad care can lead to avoidant health behavior. And the internalization of these phobias, homophobia and transphobia in society, can lead to depression as a sense of helplessness, or other coping behaviors, for example, substance use as a way to self-medicate when growing up in a society where one's lived experience is not acknowledged or recognized or affirmed. There are conceptual frameworks for this. One of the common ones is the minority stress framework, where there's these external stigma-related stressors, and these can potentiate behavioral health problems leading to physical problems. But as mentioned, there are other things that are not necessarily the internalization of societal factors, but specific behaviors such as specific sexually transmitted infections. Two other frameworks that I want to mention before talking more specifically about the documentation of sexual orientation and gender identity in healthcare system. One is intersectionality. We also have to have a certain level of cultural humility and realize that individuals are more than the sum of their sexual orientation or their gender identity. So particularly for people who are from communities of color, there may be experiences of racism, ethnocentrism by communities of gender and sexual minority peers who are not racial minorities, but these same individuals may also be experiencing the same homophobia and racism. This can lead to synergistically negative health outcomes. So for example, the rates of new HIV infections are disproportionately high among Black MSM, not because of increased sexual risk-taking behavior, but because of concentration of infection within the community because of what's called assortative mixing, people being more likely to have partners from within their own community, and also because of avoidant health behaviors, mistrust and lack of access, economic insecurity leading to less engagement in preventive health services. But the flip side of this is resilience, and this is something that we don't spend enough time doing as health professionals and as researchers, which is basically saying that in the face of a lot of societal homophobia, transphobia, if you just look at what's been going on in Texas this past week or some of the statements made in Florida, we certainly know that these are active issues. But in the face of this, the majority of sexual gender minority people are leading healthy, productive, fulfilling lives and trying to figure out what are they doing right and to try to help develop programs that help support people who are facing challenges is an important part of the work ahead. So one issue that has in the past been kind of a major red herring in this work is that some providers said, well, I don't ask my patients about their sexual orientation or their gender identity, and that's what SOGI stands for. I don't ask my patients about these issues because they may be offended. And, I don't know which of my patients are gay or straight. And if I ask the wrong patient the wrong question, they're going to be traumatized or they will leave the practice. We actually did a study. My colleague Sean Cahill was the lead author, published in PLOS One a number of years ago. We took 4 health centers, 2 that had as part of their mission statement serving sexual gender minority populations, and 2 that did not. One in particular was in the Deep South and had primarily an African American population. And we interviewed more than 300 patients accessing care at these 4 community health centers. And we found that the vast majority, well in the high 80% of patients, felt that asking about sexual orientation and gender identity routinely was something that they considered part of good primary care. And when we looked and said, well, were the people identified as heterosexual, did they feel this as much as the people who were sexual gender minority individuals? And the answer was yes. So that it's not an issue for patients, at least from that study. Another study conducted by a colleague in Boston and with a national sample found that the majority of clinicians felt that patients might refuse to provide information about sexual orientation, but they also interviewed parallel panels of patients, and only about 10% of patients said that they refused to provide these data. And there was another study that found that the majority of people, vast majority of people, were not offended by having sexual orientation, gender identity questions on intake forms. Only a minority, that there were some people, but very small number, reported that they would be distressed, upset, or offended by these kinds of questions. So then the next question is, if we think that these data are worth collecting because they're actionable and can lead to improved healthcare services, when do you collect the data? And the answer is you could send people a web link and they could fill out the information at home with pre-registration. They could fill it out at the registration site, or they could fill it out with the provider. And my colleagues at the Fenway National Center for LGBTQIA Education have put out a number of monographs, and I'm going to feature some of these that have tools. And if you go to our website, you can download these. So this one talks about how and the best practices for collecting sexual orientation, gender identity information. Then which questions do you ask? And this is still an area of active discussion, but certainly this is one of the more standard questions on the questionnaire. And then gender identity, there are some additional questions that one would want to ask. One would want to know about the preferred name that somebody has, not necessarily the name on their birth certificate. What are their preferred pronouns? Knowing what's on the insurance record so that people on the front desk can know what they should be saying to somebody when talking to the patient, but what they should be filling out when dealing with billing. Certainly knowing that gender identity may be fluid, so asking about current gender identity, and certainly knowing about sex assigned at birth. And another concept that we talk about a lot at Fenway, which I think is important, is an anatomical inventory. This wouldn't be something that you'd collect at intake, but important for clinicians to keep in mind that knowing sex assigned at birth and knowing current gender identity doesn't tell you necessarily what to screen for, because certain body parts may be present or not present. So it's important to get that information as well. In thinking about collecting these data, certainly for clinicians, there's a need to know about what are the different health behaviors, health conditions, what differentiates sexual gender minority people from other individuals in terms of their expression of health conditions and prevalence of health conditions. Non-clinicians don't need to know that, but certainly having a sense of the difference between sexual orientation, gender identity, what are best practices for communicating with sexual gender minority patients, and how do we achieve quality care and monitor it. And certainly we want to educate patients so that patients understand why we're asking the questions, that it's not research, but it's to improve their patient experience. There are a number of things to keep in mind. Certainly, there's training that's important for documentation and for interaction with patients in terms of using a language that is more affirming of more diversity in terms of people's sexual orientation and gender identity. And again, we have a monograph on that. When we train, we provide guidance also about thinking about posters and other educational materials that clinics have that have inclusive language so that people can see themselves represented in the clinic and can feel welcome. And then part of the training is dealing with the fact that we all grow up in life with various biases. This is part of being human, but there are ways to recognize our implicit biases and to try to address them so that we minimize any kind of downstream negative impacts for our patients. So I had mentioned before our National Center for LGBTQIA+ Health Education. This center has been funded by HRSA to be one of the National Technical Assistance Centers for federally qualified community health centers focusing on sexual gender minority health. So it's provided training and technical assistance, grand rounds, a lot of online resources that are available. And again, I'll keep shamelessly plugging our website. It also has offered ECHO training programs for distance learning and group problem solving, and there are a variety of resources and publications available on the website. The center has been very successful in recent years, and there's been increasing recognition of the need. So entities that are not community health centers, healthcare systems, teaching hospitals, city health departments have also asked the what we call the Ed Center to help provide some training. So this brings me to just sharing with you some empiric data. The Ed Center, like many of these programs, is very rigorous in collecting pre and post intervention, pre and post educational materials about how did people feel the sessions were, how they were useful, feedback for new sessions. And the focus of the Education Center has been in community health centers since we are based in a community health center. And it sort of made sense to me that we hadn't really rigorously evaluated what the impact of the training is. Community health centers are a really important place to look at this because as many of you know, they serve a huge part of the US population, more than 18 million patients. The patients tend to be economically disenfranchised. They tend to be located and or serve a high need community, and they provide comprehensive services. And people who come are there because regardless of inability to pay. and there's community board of governors. And what's also notable is that as recently as 2016, HRSA, which provides substantial funding for community health centers, asked that sexual orientation gender data collection be part of the uniform data system of that they collect, the report that they get annually. So one of the questions we had was, gee, if a center gets some intensive training, does this improve their collection of data related to sexual orientation, gender minority, and healthcare needs? So we designed a study in conjunction with 3 of our partners from a collaboration called CHARN, the Community Health Research Network. OCHIN was one of the partners. Other partners were the Alliance in Chicago and APSHO, the Association of Asian Pacific Community Health Center Organizations. And so our specific partners and our extended network partners identified 12 community health centers that were interested in potentially getting the training. And they had to agree to be randomized to either get training right away or at the end of the study be offered more intensive training. And you can see here, we selected a heterogeneous group of community health centers, a mix of rural and urban, ACA state expansion, differences in size in terms of race, ethnicity, and insurance mix, and poverty indices in these health centers. And what we initially did before randomization was we did a qualitative interview in 6 of the health centers with key people, with clinical and administrative leadership at the health centers, and just what were their attitudes about training around sexual orientation and gender identity. And we found that the barriers identified were that people said, well, we don't have enough training. We're concerned if we offer this training, our staff may not respond well to it. We've got so many other things we have to do. And then there was an interesting one, which is basically saying, if we train in this, are we going to have to train every other minority health concern? Because we want to make sure we don't want our providers to think that we're privileging one group over another. And we had to sort of recognize that some people were not understanding that this was an equity issue, that there were substantial health disparities to get sexual gender minority people care and the level of care up to that of general population, that some additional training would be warranted. There were also facilitators that were identified. Certainly, some of the health centers said that they already had relations with other organizations, such as community-based organizations that helped provide some cultural awareness about sexual gender minority health issues. Some had staff who had prior training and knowledge, and some already had active initiatives focused on sexual gender minority care. So in general, we found that clinical leadership had strong support, but certainly had some residual concerns. But again, we also found this idea of going from equality, that one size fits all, to more of an equity-based approach to identifying where the disparities are and trying to train up around those issues. So this helped inform our intervention. And what we basically found in the at the baseline was quite interesting. So we looked at the 2018 UDS data from these 12 community health centers before randomization, and we found that despite the request from HRSA that these data fields be completed, we found that it was quite a wide range in terms of the data being missing from UDS reports. One clinic provided this data on almost 100% of their patients, and one on almost none of them. And similarly for gender identity, even a little wider swath in terms of the range of documentation. We also found that community health centers were more likely to report body mass index and tobacco screening as routine measurements, but they were less likely to report hepatitis A and B vaccination. We wanted to look at whether there were disparities by sexual orientation, gender identity. We also found that transgender women were less likely to have mammograms than cisgender women. And transgender men, or those who endorsed another gender, were less likely to have cancer screens, hepatitis vaccination, or alcohol referrals. So some suggestions, though not dramatic, that there were some disparities, but what particularly jumped out was the wide variability in reporting. And you can see here just in terms of some of these different measures that HRSA requests be documented, that quite a large variability across the groups, and that many of these areas were not as well documented for cisgender heterosexual patients as well. So the only big disparity around sexual orientation was alcohol referral for people whose sexual orientation was marked as something else. With regard to referral in, by gender identity, you can see that transgender individuals, there are a variety of conditions that they were less likely to be screened for than cisgender individuals. So this brings us to the intervention. So the intervention, basically, we tried to pair the community health centers and had 6 community health centers in one group and 6 in another group. And one group got standard of care and the other got the intervention. So the standard of care condition was basically a passive acceptance condition, because in our focus groups, we found that among the 12 community health centers, none of them wanted to be in the control condition. In other words, the community health centers that were willing to participate in this study were community health centers where the leadership felt that the training would be helpful. So they felt that it would not be acceptable for them to be in a study and for us to be monitoring data and for us to do nothing, because the premise was that doing something would be helpful. So it wasn't a pure standard of care condition. It was more of an augmented usual care condition, because people were told, here's a web link, there's a 60-minute online webinar, and it contains a variety of things, foundational concepts of defining what is sexual orientation, gender identity, and what are sexual gender minorities, talking about stigma and the health disparities that sexual gender minority patients face, the importance of sexual orientation, gender identity data collection, how to do it, how to ask people, how to achieve equity in care, data quality, communication issues. So a fair amount, but again, only 1 hour, and nobody was obliged. So it really was the health center's decision about who actually took this 1 hour training. The intervention condition was more intense. There were 2 phases. There was a readiness assessment, which included assessment tools, one for staff and one for leadership. These assess the staff's knowledge, attitude, skills, practices, policies. These were adapted from Joint Commission Field Guide and to achieve advancing LGBT health, and the Human Rights Campaign's Health Equality Index. And then the Ed Center reviewed these key documents and forms and came up with sort of a plan, and the data was and the plan was presented to leadership for their buy-in. And then, using a framework established by Kern for curriculum learning, specific needs were identified, and there were a repertoire of teaching and learning activities that were selected, and a curricular plan for the site. And each site was asked to have a site champion to help promote the work. And at a minimum, everybody in the health center was asked to view a 10-minute video showing patients describing their experiences and their needs accessing care. There was an interactive group discussion of the health priorities described by the patients in the video. And then there was a didactic session for clinicians, administrators, and patients. So one session for everybody together as a group. And this covered a lot of the things that were covered in the control condition video, but it was an opportunity for it to be an interactive session as well as a didactic session. And then what's most important, number 12, is that this intervention sites were offered additional live trainings to clinicians, managers, and board members. And this is just to give you a sense that the clinics really handle this all differently. So although we asked to have site champions, 2 of the clinics really weren't able to identify one and sort of shared the responsibility. 4 of the intervention clinics did have identified site champion. In terms of the trainings, everybody got the all staff training, the 1-hour interactive training, but 2 of the health centers elected not to have leadership training, and 4 elected not to have additional training for the clinical staff or the administrative staff. So you can see in terms of the absolute numbers of trainings, it really varied from 2 trainings to 10 trainings. And in terms of the percentage of the staff trained, it ranged from 17% of the staff to 100% of the staff receiving some training. So you can see different levels of engagement with the intervention itself. So the next few slides are sort of the take home, and it's not as satisfying from a research standpoint as one might like. I think just to summarize, I think the main take home is if you've seen one community health center, you've seen one community health center. In other words, lots of different patterns with the different community health centers, and we're still in the process of analyzing the data. So these are relatively fresh off, hot off the press. And so in blue, the dots in blue are the intervention community health centers. The dots in orange are the control community health centers. And what you have is the rates of documentation of sexual orientation on the top, and the rates of documentation of sexual, or excuse me, of gender identity on the bottom. And the x-axis is the rate in 2018, and the y-axis is the rate in 2020. So what you'd like to see are the blue dots starting off very low and going very high. So for example, I don't know if if you can see the arrow here, but there's one which is if you look at the 2018 rate, it's about 10 would be about 10%, but by 2020 was 80%. So this is what we're hoping to see in all 6 of the blue sites. But we really only saw it in one. One of the health centers stayed low for 2018 and 2020. At the other extreme, near 100%, there were several health centers that had very little room to grow because they were already doing very well. So 2 of the control health centers stayed pretty high, and 3 of the intervention ones started high and stayed high. So it's very hard to show an improvement there. There are 4 of the control health centers that, if anything, showed a modest improvement over time. And the data are fairly similar for gender identity. Now, there are a number of things going on that make this a very funky study. Number one, if you think about the timing, we started the study pre-pandemic. 2020 data, not easy data to interpret given the effects of the pandemic. So, we can't plan a pandemic or account for a pandemic in the middle of the study. So that may explain that the findings aren't as clear cut as we might like. We also tried to look at differences in various kinds of screenings. So we took something that was not specifically associated with sexual orientation, gender identity, body mass index, and just said, how are the health centers doing before and after the training? And what you can see here is the tyranny of small numbers. So all the blue boxes are a bit higher than the orange boxes in these box plots. So you can say, if you eyeball it, and on the y-axis is the percent change. So there's more positive values in the blue boxes when you look at whether it's sexual minority, for sexual minorities or for gender minorities in community health centers. You can see that there's more BMI screening for sexual and gender minority individuals after the trainings, but these were not statistically significant because the whisker plots show that they overlap substantially. So a trend, but not a statistically significant finding. And similarly, PHQ, when we said that there's a higher prevalence of depression, we don't know if this is a function of the pandemic, but in some places there was less documentation of PHQ-9 in 2020 than there was in 2018, unfortunately. But again, the blue boxes tend to be higher than the orange boxes. So there's a trend, but not a statistically significant one, towards more documentation after having the trainings. So not a simple message for the specific intervention study, but there's some key lessons I think that are important that we learned. Number one is that the community health centers, they're very heterogeneous. So training to improve care for sexual gender minority patients really needs to be individualized. Because of the heterogeneity of these community health centers, and because it was a small sample of 12, it was not feasible to show significant improvement in documentation and appropriate services in the intervention compared to the control condition. And not having a pandemic might have also made it easier to show differences. But unfortunately, even though PCORI was very generous in providing support, we really weren't able to have a larger sample. And there really was sort of a self-selection bias in the trial, in the sense that there are a lot of community health centers that weren't particularly interested in being in such a study. And those are perhaps the ones that might benefit the most from such training. So what you have are places where people, even in the control condition, had a fair amount of buy-in about the importance of these issues. So even though they may not have gotten the Cadillac version of the training, they had access to lots of resources and were aware that they were in a study looking at these issues. So there may be what's called a Hawthorne effect, where there's a just knowing you're being observed in the course of a study around, and knowing that you're in a study focusing on these issues, led to sort of heightened improvements at local level, even without the further support of the training. So again, it may be more helpful to have a larger N and to have less of a coalition of the willing, but that's always challenging to go into community health centers and add something that might entail more work and to not have buy-in. So it is something of a conundrum. And we also can't dismiss the fact that the control condition could be more influential. In other words, it did provide resources. It directed people to the Fenway website, and we're hoping to get better sense of whether people who were in the control condition use these resources. So that may explain some of the improvements as well. One thing we did find was that the feedback from the trainings was highly acceptable in all the sites, lots of engagement. And so we certainly think that there's adequate demonstration that the trainings are helpful, but the question of how to show improvement, or what the appropriate doses of training, it's going to take time to figure this out. And I think, again, getting back to this idea that you've seen one community health center, there may be a need for additional tools to kind of stage people to figure out what dose of the intervention is most helpful for them at different stages of the clinic's work life. So we certainly need more work to develop a wider array of community health centers that to determine what are the characteristics of community health centers that will benefit the most from additional trainings, and what different ways can we train, particularly given the access we have to new technology, doing things remotely. So what is best done remotely, what's best done in person, and what kind of reinforcement for trainings for quality improvement might be helpful as well to improve the quality of care for sexual gender minority individuals. So I just want to thank you for inviting me. I want to make sure that there was time for Q&A. I want to thank my colleagues at Fenway, Chris Grasso, Matteo Peretti, Max Siegel, Dana King, Stephanie Lou Askerulian, and Sean Cahill. And also, this was a collaboration with your colleagues in Portland at Kaiser Permanente, Marianne McBurney, Phil Crawford, Suzanne Gillespie, and Ning Smith. And certainly want to thank you at OCHIN for being part of this study, from colleagues at the Alliance APSHA and other participating community health centers, and our project officers at PCORI. And thank you so much for your attention. Look forward to your questions.
Thank you, Jen, and thank you, Dr. Mayer, for that fantastic presentation today. And thank you to everyone who attended today's session. Follow Fenway Health on Twitter at Fenway Health, all one word, at Fenway Health, and visit their website at fenwayhealth.org. And be sure to follow Ochin on Twitter at Ochin Inc. That's at OCHININC, all one word, at Ochin Inc. and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our Ochin YouTube channel to catch up on past Grand Rounds presentations. And stay tuned for next month's season 6 finale of Ochin Grand Rounds on June 28th, as we welcome Dr. Natalie Huge of Oregon Health and Science University as she presents on the impact of the Affordable Care Act on community health centers. Invitations to this event will be sent 2 weeks prior, but if you are not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at Ochin and Dr. Mayer, to all of you, have a wonderful rest of your day and stay healthy out there.